Yes, I'm Benjamin Levy. I'm a lung cancer doctor. I'm an associate professor at Johns Hopkins School of Medicine. How to sequence immunotherapy with palliative radiation in a stage 4 lung cancer patient is a very challenging issue and question, and we're still learning a lot about how to do this in 2021. What we have learned is that radiation is playing a more important role, not just for cure, but for palliation, and also potentially integrating radiation for oligometastatic disease, however you want to define that, where if you have only 5 sites of less of disease, one maybe in lung cancer could consider radiating all sites to try to push the envelope. So we are partnering more and more now with our radiation oncologists. But what this has brought into high relief is, and thrown into question is, well, what do we do with these systemic therapies when we do give radiation? And it's a tough call, and it's a nuanced call. I would say for immunotherapy, for patients that are getting definitive radiation for cure, we generally don't give immunotherapy concurrently. But I only mention that because we may have data soon to suggest, we do already, we need larger data, to suggest it's safe to give concurrent checkpoint inhibitor with radiation for curative intent. So if it's safe in that setting, perhaps it will be safe in the palliative setting as well. Generally, and I think every thoracic medical oncologist may have a different answer here, I generally like to hold the checkpoint inhibitor during the palliative radiation. The hope is that the radiation is only 5 to 10 fractions at the most part. So usually we can just delay 1 week or delay 1 or 2 weeks, or just hold on one therapy and resume the next scheduled therapy. If the radiation becomes more prolonged, it becomes more challenging. I think the biggest issue and the challenge is, what's the toxicity going to be, specifically as it relates to pneumonitis. So a lot of the times in lung cancer, radiation is given palliatively to the lung and to other areas involving or near the lung. And we know that there may be this toxicity overlap between radiation and checkpoint inhibitors. And so to avoid pneumonitis, I generally do consider holding it. So let's say I have a patient who is on single agent checkpoint inhibitor. They then develop oligometastatic progression, or they have growth and, let's say, a paraspinal mass in the back, in which all of their sites of disease are stable other than that paraspinal mass. We will refer them to the radiation oncologist. The radiation oncologist will plan to give the radiation. I will talk to the radiation oncologist and make sure that during those 10, 15 fractions, we not give the checkpoint inhibitor. All of this really highlights the importance, and I know it's not a part of the original question, but it takes a village. There has to be optimization of the communication between the medical oncologist and the radiation oncologist as we begin to understand and sequence these treatment strategies for patients with advanced stage disease who are on checkpoint inhibitors.